name's Carolyn Warner-Greer. I'm a board-certified in obstetrics and gynecology and addiction medicine, and today I'm going to talk about opiate use disorders in pregnancy. What's an opiate use disorder? Well, it's actually a diagnosis which has some criteria. And basically, it's someone who uses opiates, either prescription pills or certain things like heroin or fentanyl, and it has criteria. The most significant criteria is just knowledge that I'm using a substance and I can't stop even though I know that there's a problem with it and it's making my life bad. It has some physiological criteria such as I'm tolerant to the substance, meaning I use more and more and more to get the same effect, and withdrawal symptoms. If I don't use this substance, I'm going to have certain physical effects. It has some external consequences such as I'm taking risks, meaning I'm doing things that I would normally not do, but I have to. It means I'm having problems in my job, or I'm having problems in my relationships. And it has some internal consequences, such as I have cravings for the drug. I'm using longer than I want to, or greater amounts than I want to, that I spend all my time circulates around either recovering from the effects of the drug or spending time getting the drug. When people meet certain numbers of these criteria, they either have a mild, moderate, or severe opiate use disorder. When people are diagnosed with this is actually a psychiatric diagnosis. It's an illness. Nowhere in there does it say I'm a bad person and I want to go out and do things so I can have fun. If I lined up 10 people and I gave them hydrocodone tablets, which is prescription opioid, statistically, 8 of them would feel nauseated, itchy, dizzy, and say, I don't want that anymore. That's a bad experience for me. But statistically, 2 of them would say, I feel great. I feel like a warm blanket's on me. I feel secure. If I had anxiety, it's gone. If I had depression, it's gone. And those 2 people would probably seek out that feeling again and again and again, even if there's evidence that it's not a good thing for them. Those people would have a higher risk of developing an opiate use disorder. What made those 2 people and those 8 people different? Well, one of the things we know is genetics. We know probably about 50 to 70% of developing an opiate use disorder has to do with genetics, who your family was. When I see new patients, they frequently say, this happened to my mom, this happened to my uncle, this happened to my grandparent. It doesn't always have to be the same substance, but it usually is a substance. The other thing we know that's involved in is trauma. We know that if a woman is sexually or physically abused sometime in their lifetime, they have about a 26 times greater chance of developing a substance use disorder. A psychologist told me once that instead of asking women what they did, start asking what happened to them in the first place. The third thing we know is just the timing of exposure. We know that the brain is not completely developed in making planning and executive decisions until they're about 25. So if someone's exposed to these substances when they're 14 or 15, they simply can't make plans to avoid it any longer. So when someone has a substance use disorder, specifically an opiate use disorder, they're not thinking rationally to say, I'm going to avoid that. Their brain has been changed, and we've demonstrated this over and over and over again. Their brain has been changed, and they don't have the ability to stop using it because their systems of reward and memory and motivation have been changed. So then we have a pregnant woman who has been found to have an opiate use disorder, and she finds she's pregnant. In the past, what we did was we would have those women go to what we call detox or withdrawal management, and we would stop those opioids. The first thing would happen is that they would have a painful physical experience from opioid withdrawal. And then we'd send them out and we'd say, don't use drugs anymore because you're pregnant. The outcome of that was about 90% of women would continue to use drugs. And it wasn't because they didn't care about their baby, and it wasn't because they were bad people. It was just simply that's a manifestation of their disease. When a pregnant woman is continuing to use opioids, it's very likely, one, that they're not going to seek obstetrical care. Okay? No one wants to go see a doctor and have to lie about what's going on, or fear of getting caught, and fear of having their other children removed, or fear of having them be reported to the authorities. So we all know that a woman who is not seeing a doctor for their pregnancy is probably not going to have a good pregnancy outcome. So it makes sense that we need to treat women appropriately so they don't have to continue an active addiction and they get prenatal care. We know that asking women to just stop using is not going to result in abstinence from use. So the standard of care for women with opiate use disorders is to use medications that are effective. 1, to make sure that they get good care, and 2, to prevent return to use, which happens about 90% of the time. The medication that we've used most frequently in pregnancy is methadone. It's been used for decades. It's not associated with any birth defects. It's been shown to keep more mothers in treatment, meaning fewer women once started on methadone drop out of treatment. It's not found to have a decreased birth weight, and when used appropriately, not associated with premature delivery. In 2012, we found that buprenorphine, which is also an opioid agonist, although slightly different than methadone, has also been useful to treating pregnant women with an opiate use disorder. Buprenorphine is different that it can be delivered in an office setting versus a special opioid treatment program. Therefore, it increases the access for pregnant women, that they no longer have to go to one spot and they have to attend every single day. Now they can go to offices, even their OBGYN, and get their medication and not have to attend daily. When methadone and buprenorphine have been compared head-to-head, it's been found that buprenorphine is associated with slightly less incidence of withdrawal syndromes when the baby is born. For that reason, buprenorphine often is the first choice for treatment, although, as with all medicines, not one medicine works perfectly for every single person, and treatment always has to be individualized. Sometimes pregnancy is the first time where moms feel that they have a chance to get out of a cycle that they don't want to be in, that they can ask for help, they can get definitive help, not just for their baby, but for themselves. Opiate use disorders are very amenable to treatment, not just during pregnancy, but the rest of the life, so moms can be good providers for their children, for their families, and for themselves. If you have questions about an opiate use disorder and treatment, please feel free to reach out to your OBGYN.